This is LiveWell Talk on Advances in Gastroenterology. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health, St. Luke's, Cedar Rapids. March is an interesting month. It has the Ides of March, spring break. It's National Celery Month, but it's also Colon Cancer Awareness Month. And this March is extra historic because our go-to gastroenterologist, Dr. Abramson, will be retiring after 30 years in practice here in Cedar Rapids. I did meet him once, probably in 1991, and he did have hair at that time. We put in his, I worked for Fleming Irrigation. We put in your sprinkler system, Dean. I hope it still worked. But joining me today, he's going to talk about not only colon cancer, but also kind of take a look back at gastroenterology and some of the milestones that we've seen in technology. So, Dr. Abramson, welcome back to the podcast.
Thank you. So I think you and Tony Carter both put in our sprinkler system.
Yep.
And remarkably, considering the two docs in the making were working on it, it did work. So
good.
Excellent.
Glad to hear that.
So when I finished my fellowship in 1989, colorectal cancer screening was very different and very disorganized. So there was no such thing as screening colonoscopy at that time. And there weren't really recommendations for occult blood testing either. And certainly the Cologuard DNA test didn't exist. So we were doing colonoscopies at the time on people with symptoms, rectal bleeding, changes in bowel habits. And we had known for 20 years beforehand that there was what's called the adenoma carcinoma sequence, that colon polyps, adenomatous polyps, over 5 to 10 years could become colon cancer. So we all kind of intellectually knew that if you intervened in that sequence of events, you could probably decrease the risk for colon cancer development and subsequent death. But that took many studies over the years to actually prove. So the first study that suggested survival advantage for screening colonoscopy was in 1993, the National Polyp Study. And that was with 8 or 10 different large institutions, pooled data, and they showed a survival advantage for people who underwent a single colonoscopy with removal of polyps. And subsequently through the years, there have been multiple additional studies that have reconfirmed that and at this point show a strong survival advantage for colonoscopic screening and in fact all colorectal cancer screening. So really, I think Ronald Reagan in the mid-'80s developed colon cancer, and that kind of put it on the map a little bit. And then what really put it on the map was when Katie Couric's husband, Jay Monahan, died in his early 40s of colon cancer. And she went on to have a live colonoscopy broadcast on the networks in 2000. And that, I think, really demystified the procedure for the average individual. Meanwhile, Center for, it was huge at the time, and I think people today maybe don't remember it, younger people. But simultaneous with that, the Centers for Medicare and Medicaid Services were meeting, and in 1998 they approved screening colonoscopy for people with family history of colon cancer and a first-degree relative, and in 2001 they approved it as a simple screening exam for prevention of colorectal cancer. Prior to that, sigmoidoscopies were being done, which examined maybe the lower third of the colon, and people were referred on for colonoscopy if they had polyps. But as I said, there really wasn't any organized screening program. So CMS covers Medicare people, so age 65 and older. So it always takes a couple of years for the commercial payers to catch up with CMS, but in fact they did. And so in the early 2000s, screening colonoscopy became an everyday thing starting at age 50. And I think thanks to people like Katie Couric, there was good adherence to it at the time. The Affordable Care Act of 2010 mandated free colonoscopic screening as a Medicare preventive service. Again, the commercial payers find ways to tack on extra charges, but they did catch up. And subsequently, a loophole was closed in 2020 again, for Medicare, because what would happen is people would come in for a screening colonoscopy, have a polyp removed, and all of a sudden it became a diagnostic colonoscopy with additional costs. So HR 1570 took care of that finally in 2020. Again, commercial payers slow to catch up to that for younger people.
And I know I've had patients, or I know patients where that did happen to prior to that law change.
Absolutely. Yeah. So not a good thing in terms of driving up the costs, and people understand it's a screening exam. We're doing it to find polyps, so why should they be penalized if we find polyps?
Right.
Kind of crazy. I think it's getting better and better. And in addition, the commercial payers had another trick where if you had a colonoscopy because you had a positive occult blood or FIT test of the stool or positive Cologuard test of the stool, they found a way to make that into a diagnostic rather than a screening study. And they are getting better about that, and that seems to be going away with most of the payers, but not all.
Speaking of, can you just briefly touch on what I think the massive disadvantage to the Cologuard or the FIT testing?
Sure. So, I mean, that kind of gets into the big buzzword now is a personalized approach to colorectal cancer screening. And I think we can all agree that the optimal test is the test that gets done. So if 40% of the population that's eligible for colorectal cancer screening doesn't do anything, that's no good. But the non-invasive stool tests at this point involve Cologuard, which is a combination of multi-target DNA analysis as well as a test for blood in the stool. And there's that, which is recommended every 3 years, and there's a test for occult blood. Now we call it the FIT test, and that's recommended annually in people who are eligible for colorectal cancer screening. And I think if someone absolutely refuses a colonoscopy, doing any of those is better than not doing it. And a positive FIT test or a positive Cologuard mandates a colonoscopy to follow up to find what caused the positivity. But there's a definite difference in sensitivity. First of all, going back to personalized based on risk, well, I'm not sure what that means, because every American has a 1 in 5 chance of developing colon cancer in his lifetime. So that means we're all at significant risk. So I don't know that it makes sense to risk stratify, other than to say that people who have a family history of colon cancer are at increased risk, people who have inflammatory bowel disease are at increased risk. But basically, we are all at risk. So there's a distinct difference in the sensitivities of the non-invasive tests that I think gets glossed over a bit. They're not comparable to colonoscopy. So colonoscopy is the gold standard, pretty much will detect all significant sized polyps and pretty much find all colon cancers. The Cologuard test that's promoted so heavily on television commercials will miss 8% of colon cancers that are present at the time of the test. To me, that's not a great test. It's better than nothing. As I said, it will miss 40% of advanced polyps as well. And the FIT test for blood in the stool, microscopic blood, is worse than that, because it will miss a good 20% of colon cancers present at the time of the test, and it will miss at least 60% of advanced colon polyps. So there's a distinct difference. So if someone were to hear his choices, that you've got these two non-invasive tests and you've got colonoscopy, if they heard the differences between them and they still decide on a non-invasive test, I think that's great if they're informed. But I see all too often that patients are not informed. It's a time-consuming discussion to have with a patient.
But it's a valuable discussion, because I've had patients say, well, I don't want to do the prep because it's horrible. I said, well, metastatic colon cancer is horrible too, so I would take the prep. And it's like a lot of things in life, it's in the sales pitch and taking the time to make sure you have that thorough discussion and it's informed consent. Now, it seems, and you mentioned this you've mentioned this to me in person, but as well on a previous podcast, younger patients are getting affected, and that's obviously a change in something. What is your observation for that?
So there's changing tumor biology. Nature will always try to outsmart all of us. And for whatever reason, Younger adults are developing colon cancer. Obviously, Jay Monahan, Katie Couric's husband, did this before it was fashionable. But basically, over the past 20 years, there's been a 2% annual increase in the incidence of colon cancer occurring in individuals before age 50. And most of these individuals don't have any known family history of colon cancer that you could have picked up on, acted on either. The reasons for this are not entirely clear. Things that have been discussed are epidemic obesity, poor diets that are high in red meat, low in fiber, changing microbiome of the stool due to excessive use of antibiotics. We don't know is the bottom line, but it's a real phenomenon. And consequent to this, we now start screening colonoscopy at age 45 rather than age 50 in an average risk individual. Almost all commercial payers are on board with this at this point, which is good.
And family history, it's first degree relative 10 years prior to when they had it, right?
Correct.
It's still the
correct.
same.
So first degree relative meaning sibling or parent, and you always want to start 10 years before that index, or start at age 40. So at either age 40 rather than age 45, or 10 years before the index cancer.
Now, there takes some skills to do a colonoscopy. It's not, it's not playing a Nintendo game by any measure. But so what are some, kind of walk us through what is the standard for technique and quality metrics?
So that too has changed a great deal in my practice. Early on, it was considered great if we got to the start of the colon quickly and came out quickly, and that was considered a great exam. And then we realized that we weren't seeing the degree of protection from colon cancer that was suggested in these studies. We were seeing what's called interval cancers pop up, and the interval is defined as between the scheduled intervals for the next colonoscopy. And we said, why aren't we duplicating what was shown in these national studies that were done with expert endoscopists? And the reason is that quality matters. And the things that matter are good bowel preparation so that you don't miss lesions. Or if it's a not so good bowel preparation, doing your darndest during the exam to clean everything, all the mucosal surfaces off, and providing a good exam, but also taking your time. So when you're doing this withdrawal, it should be slow. The standard now is 8 minutes or longer as an indicator of a quality exam. And that in turn is reflected in what's called an adenoma detection rate. So people who take time now will detect polyps in approximately 40% of individuals. So that is up, and that's been shown nationally. Everybody who follows these quality metrics has improved his or her detection rates by at least 10%. So what was previously considered a quality exam with 25% adenoma detection, you should now be detecting at least 40%. So the actual technique has greatly changed in my years of practice. And I think that all quality endoscopists across the country have bought into this.
Well, I know our endoscopists, your partners, and you yourself have role model adenoma detection rates, right? I mean, you guys are all above 40%.
We're all well above 40%. Another interesting change in tumor biology is the increasing appreciation of an alternate pathway to the adenoma carcinoma pathway. There's something called a serrated polyp pathway, and these are flat lesions that are very subtle endoscopically. I think for years we just didn't appreciate that they were there. And that also explained these interval cancers that we're developing. These have a predilection for the right side or the beginning of the colon. They're extremely subtle, and they go through a more accelerated pathway to colon cancer. So over 5 years, say, rather than 10. They're thought to account for 25% of all incident colon cancers. So I think, looking back on it, I know that I used to see these and think they were nothing, and I think everybody did that. So that's been a big change as well.
Well, in addition to colon cancer, sometimes patients can present with diverticulitis, an inflammation of a diverticuli, and should they be screen for colon cancer at some point in the future if they present with that, and let them recover? What's your thought on that?
I think the standard is if someone has his first episode of diverticulitis, and CT proved diverticulitis, so not a clinical diagnosis, but if you see it on CT scan and they get treated, they should have a baseline colonoscopy, because rarely other intraluminal pathology can either appear to be diverticulitis or precipitate diverticulitis. So that merits a colonoscopy, regardless of age. Because we do see that in younger people sometimes.
That's always been my standard when I've taken care of those patients. Well, you've seen other things other than colon cancer in your 30 plus years. What's some advances that you've seen maybe perhaps in like inflammatory bowel disease?
Yeah, so there have been really amazing advances in gastroenterology that you're so busy when you're doing it that you don't stop and think about how amazing they are. So kind of wrapping up my career has given me pause to look back and reflect, and really some amazing changes. So in inflammatory bowel disease, and we're basically talking ulcerative colitis and Crohn's disease, the advent of pharmacotherapy for these diseases has just been dramatic. And the most dramatic is something called biological therapy. And these are large molecules that are given either intravenously or subcutaneously as maintenance therapy. So the standard that probably most people have heard of is Remicade, and that was approved in 1998 for Crohn's disease, in 2005 for ulcerative colitis. Is an intravenous medication, and it's a tumor necrosis factor blocker, and that's a cytokine. I think cytokines are big news now with COVID-19.
Yeah.
So it's basically an inflammatory response. And basically, inflammatory bowel disease is our own bodies attacking our GI tract. So you want to block that inflammatory response. So these are very potent blockers of one of the end stages of the cytokine pathway. And these have been dramatically effective. So when I think back at early on in my career of all the patients who had intractable disease, ended up going for surgery. In ulcerative colitis, that means having your colon removed. In Crohn's disease, that means having segmental resections of the GI tract. I've been sending very few people on for surgery since Remicade came out. We now have 3 other tumor necrosis factor blockers on the market. Then we have a drug called vedolizumab or Entyvio, and that is a biological compound given intravenously that is specific for the GI tract and doesn't affect any other part of the body, which intellectually makes some sense that suppressing the immune system, the entire immune system, is maybe not a great idea, but having targeted therapy for the bowel is good. So that's a good drug. We have another drug called ustekinumab now that's used for inflammatory bowel disease, especially when there's psoriasis present as well, which is not an uncommon situation. That works through a different pathway. And what's really exciting, because all of these are intravenous or subcutaneous administration, is the advent of small molecules now. And the first small molecule approved was called Xeljanz or tofacitinib, and it's a Janus kinase inhibitor, and it's taken as a daily pill. And it's so powerful that it's now been suggested to be used even in rescue therapy when people are heading toward colectomy. So that's just a daily pill. And now there is a brand new one just approved, which is an S1P receptor modulator. And that also would be a daily oral pill. That one's also used for multiple sclerosis. The tofacitinib is used for rheumatoid arthritis. So I think, anything that can make it easier for the patient and potentially less expensive is a good thing. But when I think back on that, you almost never see surgery anymore is truly amazing.
Yeah, you really don't. And for me, Dean, when I was a medical student prior to, I thought you had Crohn's disease and ulcerative colitis, and they were two. But as I got into practice, they can overlap and resemble each other and really be difficult to discern. And you do need to see a gastroenterologist to do it.
They're absolutely true. We have a whole bunch of people that we classify as indeterminate because we can't tell. And in the old days, you would send someone for ulcerative colitis for surgery, and then their disease would recur in the small bowel and realize that they really had Crohn's. So yeah, it is not black and white. There are many shades of gray between those two diseases.
Well, I think, another condition that I've seen some changes in my practice, irritable bowel syndrome. It's common. It's our strategies are at times have been disparate and just reassurance. But what has changed in your 30 years as regards to irritable bowel?
Well, pharmacotherapy has certainly advanced. So for irritable bowel syndrome, and there's irritable bowel syndrome with diarrhea, irritable bowel syndrome with constipation, mixed where people have both, or just where people have pain and relatively normal bowel habits. So it's a wastebasket term for diseases that ultimately we may find out are totally different from each other. But for the diarrhea type of irritable bowel syndrome, we kind of fell into the idea that antibiotic therapy can actually help. And the antibiotic is rifaximin or Xifaxan, which is a non-absorbed antibiotic. So it's not systemic. It doesn't cause some of the side effects of other antibiotics because, again, it's gut specific. And it's basically killing off on a temporary basis some of the normal flora of the GI tract. And people with IBS with diarrhea can get a sustained response from that. So it kind of, we found that through the back door, but it's very effective treatment, and it can be repeated several times a year as needed. For constipation predominant irritable bowel syndrome, which has maybe been an even more vexing problem, we've gone through a series of prokinetic drugs over the year, but we actually have some very good ones now that finally work, and Linzess or linaclotide has been dramatically effective and well tolerated. There's several others that have come down through the pike since then that are similarly effective, far better than anything we had early in my career. But perhaps the most exciting change for irritable bowel syndrome for me, since I'm a bit of a therapeutic nihilist, is dietary therapy. And I think there are a lot of patients who would prefer diet if possible. And the low FODMAPs diet, which was discovered by Dr. Gibson in Australia, or at least put on the map by him, about 60% of IBS patients respond to a low FODMAPs diet. And what that's talking about is fermentable oligosaccharides, disaccharides, polyols. Tell me if I'm missing one, Dustin. It's basically complex carbohydrates.
Right.
And basically, it's dramatically effective for most people with irritable bowel syndrome, and they can then slowly introduce foods back. So in fact, a lot of people who think they're gluten intolerant but don't have celiac disease, it's really not the gluten per se that's in wheat, it's the fructans that they're reacting to.
And that's why you guys do the breath test, right?
We do breath tests for lactose and fructose intolerance, but quite often I find that you restrict those when they're test positive, and they're still symptomatic because basically they're intolerant of many different FODMAPs.
Well, so I can say this, that my wife has celiac, biopsy proven, and the quality of gluten-free products have improved over the last 25 years.
Astronomically, and I think the celiac patients can thank the non-celiac gluten intolerant people for that, because if it was just if it was a niche market alone, it wouldn't have gotten as far as it has. So absolutely.
Yes. Well, we've discussed some changes that have happened with the colon and the small intestines, of course, but I think one of the historic events was gastric ulcers and how that changed. Can you reflect upon that as your career went on?
So absolutely. So again, my training was kind of at the end of the ulcer surgery era. So in the middle of my fellowship, several things came out. One, the proton pump inhibitor class of acid suppressive medications, omeprazole or Prilosec being the prototype. And that replaced drugs like Zantac or famotidine, Pepcid. And these were drugs that were dramatically effective at treating ulcer disease and also GERD. So it turned intractable ulcer patients who were going for surgeries and having half their stomachs removed, all of a sudden could be well controlled on a single pill a day. Simultaneous with this was the discovery or rediscovery of H. pylori, Helicobacter pylori, again by a gentleman physician from down under. Good things seem to happen from down under. But Barry Marshall rediscovered H. pylori and its association with ulcer disease. And this bug had been intermittently found over the preceding 100 years. There's a great physician from years ago, Bezzazero, who found it. And they found it on autopsy specimens, surgical specimens. They thought it was a contaminant, but it's real. It's a bug. It's a bug in the stomach, and it's associated with stomach ulcer, duodenal ulcer, and also associated with stomach cancer and lymphoma of the stomach, malt lymphoma. And by eradicating this bug, you can drastically reduce your lifetime risk for redevelopment of ulcer disease. So, for example, if someone comes in with a bleeding ulcer, they were on ibuprofen or high-dose aspirin. If they happen to also have H. pylori found, if you treat and eradicate the H. pylori infection in their stomach, their lifetime risk for developing recurrent ulcer with bleeding, even if they go back to some of those offending agents, is quite low. Again, we almost never see ulcer surgery anymore.
Yeah,
so
very
1-2 punch. The other interesting thing in my career is the discovery of 2 new diseases. And whether they're truly new or were always there and we don't know it, I'm not sure. But the first was during my fellowship, people started writing about what's called microscopic colitis. And that's people who present with chronic watery diarrhea, 8 to 10 watery stools a day. And they're otherwise well. They're not having severe abdominal pain. They're not having weight loss. They're not having blood in their stool. But they're basically incapacitated by the need to find a bathroom. And what was found is their colonoscopy, the lining of the colon looks entirely normal. But when you take biopsies, you find colitis on the biopsy on what visually looked normal. 2 subforms of it, collagenous colitis and lymphocytic colitis, both very much treated the same. But treatment for this is a steroid called budesonide, which is a well-tolerated steroid that doesn't have all the systemic side effects of prednisone. And it can be a short-term or a long-term maintenance therapy for them, but dramatically effective in eliminating diarrhea. Microscopic colitis is more common in the United States than either ulcerative colitis or Crohn's disease. So
why is it that you have to do, or it's favored to do right-sided biopsies to diagnose that?
The histologic changes are more prevalent. It's first of all patchy, and it's more commonly found on the right side of the colon than the left side of the colon. So that's one disease that kind of maybe was always there, and maybe we didn't biopsy what looked normal. I'm not sure. But the next disease I want to talk about clearly is a new entity that started in the 1990s, and it's called eosinophilic esophagitis, or EOE. And this is a disease of the esophagus that's present in all age groups. But they're kind of 2 classic presentations. In the pediatric population, these people have failure to thrive, persistent nausea, and vomiting. In the adult population, the main symptom is difficulty swallowing with food impaction. They're eating a meal, and all of a sudden some solid piece of food sticks in the mid-chest, and they can't get it up, can't get it down. They don't complain of a lot of heartburn, minimal heartburn at most. Classic story would more common in young males, but it can happen in either gender at any age. So if we see a 30-year-old with this history, and typically these are people who put up with symptoms for 5 or 10 years already, where they've just gotten so used to eating carefully that they don't think much of it until they end up in the ER in the middle of the night with a food impaction that won't resolve. And typically also they'll have allergies, allergic rhinitis, asthma as a kind of a triad, but not always. So this is diagnosed with endoscopy. It's got a very classic appearance. I know that we would have never passed this by as being normal. So I really do believe it's a new disease. It's thought to be allergic either to foodborne allergens or to airborne allergens. We don't know which those are, and it's probably multiple allergens. It's not IgE mediated, so allergy testing is of no value whatsoever for these people. But basically, they need to be diagnosed with endoscopy A lot of times they'll need to be dilated during the endoscopy, where they have strictures that are stretched. End-stage EOE gives you what's called a narrow caliber esophagus, where the entire esophagus is narrowed. Treatment, multiple prongs of treatment. Some people have what's called PPI responsive EOE, and just treating them with a medicine like omeprazole can help them a lot. But a lot of people need steroids on top of it. And the steroid preparation needs to be topical. So we either have them Flovent, which you use for asthma, is an inhaler. We have them swallow it rather than inhale it into their lungs. Or there's a medicine called budesonide, again, what we talked about with microscopic colitis, can be compounded into a gel and then swallowed at bedtime so that it dwells in the esophagus. Dramatically effective. But there's also diet therapy for this as well. As I said, allergy testing, which is often done, is kind of a waste of time for these people. The results are not reliable at all in predicting what the food triggers are. But there's something called a 6-food elimination diet. There's a 4-food elimination diet. There's a 2-food elimination diet. And basically, the two biggest offenders appear to be dairy and wheat. And soy and eggs are kind of intermediate. And in the group of foods that rarely but can cause it include seafood and nuts. So some people will try the elimination diets. If you eliminate 6 food groups, you gradually reintroduce them and see if the difficulty swallowing comes back. We also kind of follow them histologically by doing scopes and biopsies. And this can involve a lot of scopes. So probably a very new and interesting way of approaching this problem is with non-invasive or semi-non-invasive tests to assess the eosinophilic infiltration of the esophagus. So you can do what's called a string test, or what's called a cytosponge, and kind of put something down into the esophagus, pull it back out, and assess for the number of eosinophils or their degranulation products. And that's a way of following people to assess disease activity. Since symptom-wise, it's kind of hard because these people are so careful in how they swallow. But this is clearly a new disease that's on the map, and it's extremely prevalent.
And do we know, does it put us at risk for esophageal cancer?
It does not seem to have any sequelae in that regard, unlike GERD, for example, which severe GERD definitely increases the risk for esophageal cancer.
Well, I think fatty liver is increasing dramatically as people have gained weight in the United States or Western culture. How is the fatty liver, how has that become more prevalent in your tenure?
So, I think the leading cause of liver transplantation in the 1980s and before was alcoholic liver disease. Then came hepatitis C. We now have dramatically effective antivirals for hepatitis C that can essentially cure hepatitis C. Almost all subtypes of hepatitis C can now be cured, which again is absolutely amazing. And not only does it cure hepatitis C, but in so doing, it decreases the risk for cancer of the liver and can even improve the histology. So it can convert a bad cirrhotic liver into a not so bad one. So the days of liver transplants for hepatitis C are waning too. So unfortunately, we have this entity now which has totally taken the place, which is non-alcoholic fatty liver disease. A better name for it that I think you'll see used now is metabolic associated liver disease, because the reality is that a lot of people who have fatty liver disease have metabolic risk factors for it, and also alcohol or medications, other factors that are involved. But basically, it seems to be a disease of obesity, insulin intolerance, diabetes, and it's extremely prevalent. I think, what did I see? Like 80% of Americans are above ideal body weight, and type 2 diabetes is rampant now. So this is a real epidemic, and it's not just the United States. Within the United States, the Midwest and the South are the biggest offenders, but it's extremely prevalent in Central and South America. and interestingly, the Arab countries. So it is a worldwide problem. And it's not just that these people can develop cirrhosis, but actually the risk of liver cancer, it turns out, is quite high in advanced fatty liver cirrhosis, which we didn't appreciate early on. We thought it was going to be one of the forms of cirrhosis that wasn't associated with liver cancer. Incidence is quite high. And treatment, obviously, if you drink too much alcohol, cut that out, achieving ideal body weight, exercise, getting type 2 diabetes under control. Those are all important. And we've seen with gastric bypass surgery that fatty liver can actually just melt away as long as there is not advanced fibrosis. But you do reach the point of no return. Once you get advanced fibrosis and cirrhosis, a lot of this is no longer going to be reversible. So the holy grail really is pharmacotherapy, and they've looked at many, many things, and they've taught phase 3 trials of many different drugs. Nothing has really panned out yet, but I got to believe that there will be advances made in this field.
Wasn't metformin supposed to help with that?
Yes, so metformin was one of the drugs I used. Ursodeoxycholic acid, which is a medication that dissolves gallstones and is used for some other types of liver disease. We use for that. None of those really have any benefit for NAFLD. Actose, of all the diabetic agents, Actose seems to have some anti-fibrotic activity. So Actose is being used for it, but that's the only diabetes medicine I know. But otherwise, just getting better glycemic control is of some benefit.
So metformin could do it via that mechanism too.
It could, but in terms of specifically treating the fatty liver, no, it has no activity. So the holy grail is going to be actual direct-acting medications, just as we came up with direct-acting antivirals for Hep C. There's got to be an answer.
Well, we hope so. I had a friend from college that is post-transplant for that. So 52-ish. Yeah, doing great, but yeah. Now, I remember Andy Nash is a interventional radiologist in Des Moines, and I watched him do a TIPS procedure once, and I thought that was so cool. How did that influence your practice of these patients with decompensated liver disease?
So TIPS is an amazing interventional radiology procedure, and basically one of the dreaded complications of cirrhosis is the development of esophageal varices, which are basically varicose veins in the esophagus that bleed readily and in fact can result in exsanguination. So people with advanced liver disease get these varices. We do endoscopic procedures where we ban them. But the TIPS procedure is basically creating a shunt through the liver. So the radiologist is passing a catheter through the jugular vein, down through the heart, into the liver, and he's creating a shunt between the systemic circulation and the liver circulation, which decompresses these veins. So it totally eliminates the bleeding varices. Moreover, it treats some other liver conditions. So refractory ascites is where the abdominal cavity fills up with fluid, and people are extremely uncomfortable, bloated. They can't eat much because they have no room for a distended stomach to go, which results in protein energy malnutrition. And that's one of the cascading factors that leads to liver death is malnutrition. So you take care of the ascites, they can eat better. It also takes care of fluid in the lungs called hydrothorax. And there's a rare disease called basically hypoxemia of liver disease, where there's so much shunting that people can't get enough air into their bloodstream. So TIPS treats all of these things quite effectively. And so we first saw it as a bridge to transplant. So someone is crashing on us with these problems, a TIPS was put in, and it bought you some time to wait to acquire a liver donor. But these days, it's not just used as a bridge to transplant, but it's used as long-term treatment and management. Quite effective. It does have some complications. Rarely people will get decompensation of their liver disease from the TIPS, but it's really dramatically changed and bettered the quality of life for these patients. And it is a totally neat procedure to watch.
Yeah, I
agree.
I was already an internal medicine resident. Otherwise, I would have maybe switched to interventional radiology. It's pretty cool.
I've had the same feeling watching them. I agree.
Yeah. Well, you were instrumental in helping us get fecal transplant for Clostridium difficile infections. I like to brag that we were #1 in a #2 business. But tell us how that changed. I mean, that sounds very radical, but it has been effective.
Right. So, that's another thing that where old is new. So that had been tried through the years, even before they knew what C. difficile as an organism was. They knew years and years ago, these people with refractory diarrhea, you gave them a stool enema and it got better. And I'm told that the veterinarians used this for many years as well. So it's kind of rediscovered, but it basically repopulates the stool, so you can administer people who have C. difficile diarrhea, C. difficile colitis. Can be an intractable problem because there's so much resistance to the standard antibiotic regimens. It's such a hard bug to kill because it sporulates. And when the bacteria is in spore form, it's resistant to all antibiotics, even resistant to Clorox, basically. So they found that by administering donor stool, either in enema form, through a colonoscopy, or ingested in some form, say with a nasogastric or nasoenteric feeding tube, really the cure rate is over 90% for this. The interesting thing is they did an experiment recently where they took donor stool and they killed off all the bacteria in it, but instilled it anyway. And they had almost as good a response. So there's things in stool, other than the bacteria that we know of, that seem to play a role in treating C. difficile. So I think that the final answers aren't in this. And, because of the risk of infection associated with fecal transplant, Big Pharma is working on basically pill preparations where they try to find the good bacteria and accomplish the same thing. So far, they're not there yet either, and it may be because of this factor X that we don't know that's in stool. But this is kind of the start of a brand new field, which is probably the most exciting development in gastroenterology, which is the intestinal microbiota. So we are basically a walking zoo and a walking Petri dish. So we have different microbiomes. We have the GI microbiome, where we're teeming with bacteria and yeast and viruses, and we don't really know what. There's also the microbiome of the skin, microbiome of the lungs. So this probably has a fundamental effect on disease states that we're only beginning to understand now. So probably the bacteria that live within us and some other organisms probably determine, whether we're skinny, whether we're obese, whether we get rheumatoid arthritis, whether we get inflammatory bowel disease. It's an emerging field that we're only beginning to understand. So, people are very excited about prebiotics and probiotics. Controlled studies of these agents, haven't really come up with anything yet, because you're basically, each of those has like one organism in it.
Right.
So the entire fecal microbiome, it's like, think of a nice zoo. There are many, many animals in it. So we don't know which ones are good, which ones are bad. And, there could be untoward consequences where you treat one thing and another thing happens. So all we know is that there's tremendous work to be done with the microbiome. There are companies that will sequence your microbiome for you and give you a nice readout on the 20 most common organisms that are within you. I don't know that that's much value, but it's fascinating. For example, they've seen that kids who were born by C-section have an increased rate of asthma and allergies, and it's thought because they're not passing through the birth canal, not being exposed to vaginal secretions. So a lot of times now, OB will do a vaginal swab and put it in the kid's mouth after they're born, whether that works or not. But I mean, it makes a lot of sense, really. So I mean, this is the next frontier for, I think, all of medicine, is understanding our microbiome. And it's not necessarily numbers of organisms, but it's probably the types of organisms that are present. What we call dysbiosis is probably the cause of disease. And how we get to dysbiosis, I don't know. Certainly antibiotics may play a role. The overuse of antibiotics change our microbiome over time, and life changes it. So it's thought that we acquire our fecal flora soon after we're born. So if you look at a family, the young children will have very similar microbiomes. If you look at a husband and wife couple that have been together for 40 years, their microbiomes will be very much the same and no longer resemble their siblings at all. So there's clearly an interplay with the environment.
That's fascinating. I do, when I was a medical student in the early 90s, you kind of thought that C. diff was kind of a benign condition. That they tested for it like on Mondays and Thursdays. The lab did. They batched them, and I guess about 2007, 2008, we just really started to see this C. diff that was killing people from the community. And I still remember Dr. Kopesky doing a colectomy for toxic megacolon, and it looked like he was just holding up a big largemouth bass. It was just this huge colon from C. diff.
It's absolutely become a lethal condition. What was easily treatable with a simple, cheap antibiotic became something that recurs 40 to 60% of the time after the initial therapy, and the antibiotics to treat it have become increasingly expensive, and over prolonged courses, six-week courses. We even have monoclonal antibodies now that have some activity in people who are high risk for recurrence. But yeah, I think the fecal transplants have been dramatically effective. Unfortunately, in the era of COVID, unless it's a very impending emergency or unless you're a center of excellence, you really can't get the donor stool. I think everyone in the country was using donor stool from this Open Biome company in Massachusetts. And they, right at the start of the pandemic, they had some problems with some deaths because of E. coli that they hadn't screened for in the donor stool. And then we became very concerned that we could possibly transfer COVID-19 in the donor stool. So those are pretty much on hold now, and it was thought that these pills would finally be approved, but they don't look like they're working. So we don't have anything to substitute for them. I think there are a lot of backyard fecal transplants going on, between family members and an enema bag.
So someone else wants to be number one in a number two business.
I'm afraid we may have lost it.
Yeah, darn it. Well, Dean, thanks for joining me. This has been fun. You are a friend and been a great colleague, and I've certainly going to miss having you around. I know you'll still be around. I can still pester you if I need you, but this has really been great information. Again, this is gastroenterologist Dr. Dean Abramson. For more information or schedule your colonoscopy, talk with your primary care provider or contact St. Luke's Gastroenterology at 319-366-8695. That's 366-8695.
Thank you very much, Dustin.
Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.